So this is one of our stops on what I call the library tour. But it actually started last summer when I read something in the local paper about Commonwealth health systems not doing well financially. And they were either going out of business or bankrupt, or they were selling some hospitals in Wilkes-Barre and Scranton. And I thought that might be an opportunity because they were selling them to an out-of-state company, and that leaves a void or a vacuum in healthcare. And nature doesn't like a vacuum. It abhors a vacuum. So medicine is local. I've been doing medicine for 40 years, and medicine is local. People like to have their medicine local. So all of a sudden, I read where Commonwealth is selling these hospitals to another entity out of state. And I heard that fell through recently. So I don't even know what the future is of those hospitals. But I think people like to know who owns the hospitals, who the healthcare networks are. And so right now I work for Lehigh Valley Healthcare Network, and I thought it would be a good opportunity to go into those communities and talk a little bit about the healthcare network. But really, I'm just a small part of that. I just do orthopedics, and in orthopedics, I just do a very small part, which is basically knee replacements. You know, it reminded me of how little things can result in unintended consequences. And I just had a quick story about a few of these in my life, and one of them happens to be a building that I built down in Allentown. I don't know if anybody ever drove up the turnpike, but right at the Lehigh exit, there's a big integrated health system. I don't know if you've ever seen that building. It's 300,000 square foot. In the unintended consequences, that was built because I wanted a swimming pool. But it took 300,000 square foot of medical space to support it. But the unintended consequence is right now on that campus, we have Lehigh Valley and St. Luke's, which are two very competitive healthcare networks, and I think we're the only facility that brought them together on one campus, which I'm sort of proud of. So it's really what was originally began as a pool project for me is now a very large integrated health campus for two competitive healthcare networks. And speaking of competitive healthcare networks, the other unintended consequence of me coming to Pittston, it's my hometown, and really I always wanted to practice in my hometown. After we built that large integrated health complex in Allentown, I sort of left that group and joined another private group called Coordinated Health, because the big group I was with kind of were happy staying there, but I always wanted to expand up north, which I did with Coordinated Health. We opened a practice in Lehighton, and then we opened up a practice in Hazleton. But ultimately, I always wanted an office in Pittston. And so I negotiated with Sean Casey, who's a dentist, and he was outgrowing his office up on Oak Street across from a convention hall. So I actually convinced Emil Dioriu, my old partner, to buy that, and we planted a coordinated health flag up here in the Wyoming Valley, and then Sean moved across the street and he developed Convention Hall. So it's sort of good, interesting to know the politics, if you will. So lo and behold, Lehigh Valley buys Coordinated Health. So now Lehigh Valley had no flag planted up in the Wyoming Valley, but by default, because I wanted to have an office in Pittston, now Lehigh Valley has an office in Pittston. Simultaneously, the orthopedic group in Scranton, which I had a history with when I was in college, I was operated on by that group, Joe Caesar, when I was in college, so I knew the group very well. But Harry Schmaltz was the president of that group about 10 years ago, and they were thinking of joining Geisinger at the time, which obviously is the largest healthcare network up here. I convinced him to join Coordinated Health. So now Lehigh Valley buys Coordinated Health, and we have an office in Scranton, and we have an office in Pittston. And Geisinger wasn't that happy with us. So as soon as we opened up an office in Pittston, they opened up the Geisinger office in downtown Pittston. And then we wanted to build the surgical center up here. And what happened was the real estate developer, which was really mostly the Miracle Real Estate, at first were interested in us building a hospital here, but then they backed out and they weren't interested. They said they wouldn't allow us to build a hospital here because one of their big clients was Geisinger. And they rent a lot of space from Geisinger. So thus we built the hospital in Dixon City. So that's why there's not a hospital right now in Pittston. And so with consolidation of healthcare groups, look what happened next. Jefferson bought Lehigh Valley. So now Jefferson Health Network bought Lehigh Valley. So Geisinger, that didn't want to compete with Coordinated Health or allow us to build a hospital, so now Jefferson has a flag planted in Pittston and Scranton. And if you look at the statistics I have, we're actually bigger than Geisinger. So now we brought in a healthcare network that has 65,000 employees, 32 hospitals. When they bought Lehigh Valley was a third to half of that business. And it's about $15 billion, which is about twice the revenue of Geisinger. And so this is consolidation of healthcare networks. And then Geisinger was bought by Kaiser out of California, which is an HMO. And so they're, all caught up in consolidating and doing all these things. And hopefully it's better for the patients because, we're just worker bees in these trenches. But it's interesting to look at the highest level, what's going on. And just like, these are just my opinions, but when you talk to employees and patients at Commonwealth Health, there's not a lot of money being reinvested, which makes sense now because they're in financial difficulties. And so a lot of the patients and the employees aren't that happy. And so Kaiser, if you look online too, they are a big HMO out in California, and there are some patient complaints, whether it's true or not, where they have slower processes, services are delayed, services are denied. So who knows what's gonna happen? All I could think about is Mrs. Geisinger. If you look at the history of Geisinger in the early 1900s, maybe rolling over in her grave, seeing what's happening with all this when it was just really developed for the betterment of the community and bring healthcare. But a lot of this competition sometimes overlooked what's important for the community and for the patients. But anyway, it's sort of interesting to look at some of the history. So now our orthopedic group is combined with Jefferson, which Rothman Institute is a big orthopedic group, and I trained at Rothman. And they're bringing the Jefferson Health Plans. Hopefully that'll be good for the community up here. The name will remain, but now we are one of the top 15 largest healthcare networks in the country with Jefferson and Lehigh Valley. So I think the people will make out, because I think competition is good. I think if you have McDonald's on one corner, you can have a Burger King on the other, and I think competition is good. So that's a little bit of the history and sort of what stimulated some of this. And I go back to Jefferson. That's somebody dug up that old picture. We actually had a triathlon team at Jefferson when I was there. And those two guys are orthopedic surgeons now at the Rothman Institute. So, and talk about memories, I had to bring this up too. Somebody gave me some pictures of Pittston, and some of my great memories are of Pittston. I remember the American Theater, that marquee up there, and I always remembered the back of the American Theater, that big sign. If you go up the boulevard, you always see that. And then Pittston Hospital is in the bottom left corner. That was the scariest place in the world. I actually had surgery there when I was in 6th grade. I had a hernia operation. To this day, I could still smell the ether mask on my face. God knows how I ever went into medicine after. It just looks scary. And it's really more scary inside, but it was crazy back then. I was in the hospital, I remember, for 7 days, and I was on the cover of the Sunday Dispatch because I had to be there over Easter, and I still remember that. It was the Easter Bunny, and we were in the children's ward at Pittston Hospital way back then. It's a great story. So really the educational topic that I wanted to talk about was an update on knee treatments. And there is so much going on with knee world. Amazingly, that's all I do. When I started out, believe it or not, in orthopedics, my residency in the early 80s, we were trained in everything. And when I got out, although I did a fellowship in knee surgery, we did everything: necks, arms, trauma, 15 years of level 1 trauma, hip replacements, shoulder replacements. And now the whole field has consolidated. And all I do are knees, and 95% are just knee replacements or knee resurfacings. And, you know, whether it's good or bad, I'm not sure, but the guys getting out now, they start being specialized, so they don't even have a breadth of experience now coming out. But anyway, I think it made us a good surgeon if you were a trauma surgeon. And now, really, the last 20 years, all I've done are knee surgeries and knee replacements. So a lot of people, you know, come and they want to know about this knee resurfacing that we do. What we do is knee resurfacing, and a lot of people come to me and they say, I want that new knee resurfacing procedure. What is that? And it's under the auspices of a knee replacement, but it's not like the old-time knee replacement, nor is it like a hip replacement or a shoulder replacement. A hip replacement is they take the whole hip out and they put a new whole joint in there. And in the shoulder, they not only take the whole shoulder out and put a new shoulder in, but they put it in backwards. It's called a reverse shoulder. But in the knee, we've sort of gotten more simplified. So we don't take out as much bone, ligaments, and cartilage and put big rods up there and take out, you know, the whole knee. And what we do now, what I do, is a knee resurfacing. And that one knee that you'll see that was passed around, think of it more like a crown on a tooth, like the bottom left picture. So basically all we're doing is replacing the cartilage on the end of the bone, which is all worn out like up there, and we're just putting a crown on it. People go, well, I'll have that. I want a knee resurfacing. And that's one of the reasons we could do it as an outpatient. So literally 95% of our patients go home 2 hours after the surgery. That's one of the reasons, but multimodal pain management is another reason. So we don't have to give as much narcotics as we used to. So people say, oh, that's a partial knee replacement. I want a partial knee. I say, no, a partial knee replacement is what we passed around if only half of your knee is worn out. And remember, the knee actually has 3 components. It has the inside, the outside, and the kneecap. If any one of those components is worn out and the other 2 are normal, you can have a partial knee resurfacing. Statistically, that's a very low amount. Less than 5% of total knee patients are candidates for that, because most people will have arthritis in more than one compartment. But there are reasons to have one. You've had a fracture, previous arthroscopy, a meniscectomy, those sorts of things. Let's talk about a kinematic knee replacement. What the heck does that mean? Kinesiology is kinetics, or how joints move in space. It's sort of the natural movement of joints. How many people have a perfectly straight alignment? And I'll show you that in a second. 2%, 98% of the people are either a touch bow-legged or a touch knock-kneed, maybe 1 or 2 degrees. So actually, one of my colleagues about 18 years ago said, why are we putting every knee in 90 degrees like a carpentry cut? And he said we should reproduce normal anatomy. And so quickly, if you look at the picture on the right, it looks like that's crooked. It looks like that prosthesis on the tibia is not put in at 90 degrees, and it's not. That's put in kinematically because that's how that patient's knee joint line was. So it's basically reproducing a patient's normal joint line. We have to take out less bone. We don't have to release ligaments, and it feels more normal, quicker recovery. And so that's what's called the kinematic alignment. And on the left side, your left side, that's a partial knee crown that we passed around in the room. So that's something that we're doing now, reproducing people's normal anatomy. Bow-legged people like to be bow-legged. They don't like to be as bow-legged as they show up in the OR, because if you're bow-legged, you're going to wear out the inside of your knee quicker than the outside. Just like the heel of your shoe, you're going to wear out one side more than the other. And so that's what happens. But if you're knock-kneed, you're going to asymmetrically wear the outside. So more women are knock-kneed than men. More men are bow-legged. It's just a genetic thing. And so, women come in and say, I was never this knock-kneed. They're like this now because they're asymmetrically wearing their knee. So when we resurface the knee, we put them back to the alignment that they were when they were 21, but we don't overcorrect it. And that's how their ligaments and their body mechanics or kinematics like to be. So that's a quick discussion of what kinematics are. To that point, I just returned, lucky enough, from Istanbul in Turkey, where I was invited to participate in a world expert knee and hip surgeon meeting. And this will scare you. The premise of the meeting was to look at 265 controversies in hip and knee surgery. So if you think we know everything about hip and knee surgery, think again. In each topic that we picked up to review, there were hundreds or thousands of articles to review. And we had to distill them down to quality articles that were actually designed well, that had valuable information and valuable conclusions. On each topic we looked at, there was literally single or double digits, 10 to 20 papers out of 1,500 papers, which shows you much of the medical literature is false, misleading, or not true. So that's something that's sort of interesting. That being said, I'll just give you the results of our question. Is there a difference? So I just talked about kinematic alignment versus mechanical alignment, the old way. Is there a difference? Just because I like it, is it better? So the science says we should look at meta-analyses around the world and all the best literature. And then what we did is we presented it to 300 doctors, and we presented it in a 5-minute talk. And then there was 8 minutes of discussion, just like this crowd here. Everybody could raise their hand and say, well, what do you mean? What was the age difference? What was the genetic differences? And then we had 2 minutes to vote. And this went on for 3 days on each one of these topics. So on my topic, this was the vote. It was one of the most controversial because most docs like what they did for 30 or 40 years. But the results show that, 55, the majority of people agreed that kinematic knees result in improved patient-reported outcomes, early recovery, and earlier mid and long-term follow-ups. And it achieves a more natural joint line and better soft tissue balance. But still, 30% disagreed. So only 70% either agreed or weren't sure. So, but that's how you do science. So it's sort of an interesting thing. And we did that for 64 different topics. But one of them was cement. The number of people this week, I saw a few, but the number of people that come in with misinformation is one of my pet peeves in orthopedics. 40-year-old woman, phys ed teacher from Syracuse University came down, third opinion, and her knee was worn out. And she said, you're the third opinion. Everybody said, I'm too young. I'm too young to have a knee replacement. And, what do you think? And I said, first of all, nobody's too young. Nobody's too young or too old. I've done 22 and I've done 95-year-olds. There's just different risks at different ages. She said, I'll need a revision in 10 years and 10 years and 10 years. I said, that's not true either. These knees don't wear out like that. Historically, that's more misinformation. The reason knees needed to be reoperated on wasn't that the metal components wore out. It was that they were glued in or cemented in, so they became loose. The grout loosened. So it was called aseptic loosening. The two biggest reasons, if someone had a knee replacement years ago that they need surgery, is it loosens or they have a catastrophic event like an infection. It's not that they wore out. Now the plastic historically, or the nylon in there, did have some wear properties, but it would wear incrementally over decades, if you will. Even the old knees had survival rates of the upper 90s at 20 years. But our newer knees now, we've gotten rid of the cement. Well, not everybody. And again, that's all I do are what called uncemented knees, like a dental implant. If you have a dental implant, they don't glue it into your jaw. It grows right into your jaw. So now we've converted that technology into the knee. Change is slow. 70 or 80% of all surgeons still glue these knees in. So you have a risk of aseptic loosening. But when we uncement them in and we have modern materials, these things can almost be a lifetime knee now, even at a younger year. The metal never wears. They won't in general loosen because there's no cement, and the plastic is in computer simulators often for 20 to 30 years. So this, I'm afraid at 40 to get it done. I'll wait till I'm 60 because my orthopedic surgeon is more comfortable. Well, her life is miserable. She's a phys ed teacher. She can't go up and down the steps up at Syracuse. So we're doing that right after the new year. So that's another misinformation or fallacy. So we got rid of cement. When I started, we were in the hospital for 7 days. Everybody went to rehab. There was no pain medicine except narcotics. Drains, you had these CPM machines, you had Foley catheters, epidurals, long incisions, and then you went to rehab after 3 or 4 days in the hospital. So how do we get to doing an operation with no hospital? Half of our patients don't go to physical therapy or rehab. That doesn't mean they don't do physical therapy, but the old model of going to physical therapy doesn't always work. You know, how did we get there? You just can't go, you know, from the upper left in a hospital looking sick at a big tertiary care center to doing this. It takes pathways, protocols, pain control is absolute. And we've changed the whole selection team. There's almost nobody that we can't do as an outpatient. So these are factors that we optimize. More misinformation that drives me crazy. Your body weight, your BMI, and I'll touch base with that in a second. You're too old or too young, I just talked about that. Diabetes, skin problem, all these things can be optimized, and we can do you as an outpatient and go home the same day. Going home the same day is not as much a medical issue, it's a social issue. Somebody that lives alone on 4 floors with 6 cats and 2 dogs is not a good person to go home that day. So it's real, I always say it's not like a UPS package. We can't drop you off on the porch and say, go in and good luck. But we have all the protocols. If you have a care partner, a friend, family member, neighbor, you really need somebody that goes along preoperatively. Education is critical. We have this big educational program ahead of time. We have a 38-page book. We have videos. You and your care partner, they have to be engaged to this. If not, then go to the hospital. Stay in a hospital and get operated on. Then you're at risk for all the things that could happen in a hospital. But most people don't want to be in a hospital. That's one of the biggest advances. 92% of all surgical procedures now are done as an outpatient. So in the old days, you're in a hospital. If you're healthy and need a joint replacement, you don't have to be in a hospital. You don't need those narcotics. You don't need a lot of the things that we used to do. Age requirements. You know, we talked about that, the physical condition of a patient. I have 94-year-olds that I've done, and I have 50-year-olds that I don't do. So there's no chronologic age, there's a physiologic age. If you're 50, a smoker, overweight, diabetes, you know, venous stasis in your lower extremity, you have to take some responsibility for your health. You're not going to be done. So here's a guy, 6'7", 2 hours after surgery. This guy was from the middle of the state, and he didn't want to come in for a 2-week appointment. He goes, can I just send you a video? I said, it looks like you're doing pretty good. You don't have to come in. Here's the key to our success. So minimally invasive surgery doesn't mean a smaller incision. It means how we treat the tissues. We've learned this. We don't dislocate the kneecap. We don't have strong people retracting. And you want to be efficient. The longer you're in the OR, the higher the risk of anesthesia and infection. So, you know, our surgical time literally takes us in the ballpark of 30 minutes. and then we close the wound for another 10 or 15 minutes, but you're out of the OR within an hour. But one of the key things was getting rid of narcotics. Narcotics was our only pain management tool years and years ago. We didn't know any better. And that's a list of all the complications on the right side. It was just terrible. It was responsible for 60% of all postoperative complications. When people say, I can't tolerate anesthesia, I get sick, I say, cross out the word anesthesia, write in the word narcotics. So we've eliminated narcotics pre-op and in the OR. We give patients a week worth of narcotics post-op as breakthrough pain, but we give them 4 other non-narcotic multimodal medications, which are over-the-counter and some prescription, but they're not narcotics, and they work at different parts of the spinal cord, so you don't need as much narcotics. Our average patient takes 3 to 5 narcotic pills, versus historically, they got a prescription for 120 narcotic pills. And this was propagated by the medical industry. It's okay, it's not addictive. And then it caused that opioid crisis. We were partly responsible for that. So that was our only pain modality when I first started in orthopedics, opioids. Now we do all this other stuff, and at the bottom are opioids just for breakthrough pain. So we actually start 30 days ahead of time with supplements that we didn't learn about in college. And so we have non-steroidals, Tylenol, different supplements. So you have a whole bunch of things, that we do. Ice, elevation, anti-inflammatories. The first week, your leg will swell. It's hard to convince people not to do much the first week. So if you can never go wrong doing less the first week rather than more. And so we sort of drive that in our education. This is a key to our success. We have this 38-page booklet. We have a video joint camp. Everybody has to look at this if they want outpatient surgery, or they don't do it. These 4 simple exercises we teach, you do them 5 minutes once a day. That's why we don't do therapy the first week. Wound healing, if you look at a lot of these immunonutritional drinks that they try to sell you on the market to prepare you for surgery, we just looked at the products. Basically, they're protein in your diet, L-arginine, and fish oil. We put everybody on those a month ahead of time. Lowers your risk of infection, improves your risk of wound healing. We have a list of anti-inflammatories that we recommend to people in the office for arthritis that don't want to take anti-inflammatories. I've been doing robots for over 10 years. What's interesting is doing robotic surgery as advertised, that it's shorter, it's easier recovery, smaller incisions. None of that is true. None of that is true. It takes longer. You have longer incisions. You have to put pins in the knee. And there's other risk factors. And the outcomes are not different. So there's no difference in robotic or traditional surgery if you're a high volume surgeon. So if you've done 20,000, I think you know how to do it. Now the robots do offer a lot of advantages, and they're not going away, but if you've done it as long as I have, you know who it's good in. And it's good in severe deformities. It's a leg like that on the right, if I did a total knee without a robot, I would have to make a 1.5-foot incision to get in there. If I use the robot, I could use a small incision because I do all the planning on the robot ahead of time, and I don't have to retract and see. It's going to take me longer. She's going to have different wound issues, but that's her only choice. On the far left there, that patient was in a motor vehicular accident, and the femur looks crooked. See how crooked that is? So the femur healed in a malunion position. If we didn't use a robot, we can't put a rod straight up her femur because it'll go out the back. Well, the robot only helps you perform the surgery by the data that you put in. So maybe mechanical alignment isn't the best alignment, but the robot will help you put it in mechanical alignment, and maybe that's not the best alignment. So you're using new technology to put it in a way that may not be the best results, which is why it's not the robot, it's the data that you put in. So I think everybody should exhaust non-operative treatment well before you have this done. And there's a lot of successful treatments: lifestyle management, ice, over-the-counter anti-inflammatories, Tylenol, weight loss. When that doesn't work, injections are wonderful options. And steroids are I have hundreds of patients I inject a cortisone injection once a year for many years. Thanks. I love these libraries. I love coming here, Pittston Library. I think I may continue the library tour. I just sort of like it, you know? All right. Have a good night.